rep meeting or something at this time. Oh, you might want to take control.
Okay. Right. Okay, so thanks for coming, guys. Hope you're all doing well and safe. So Anush is going to be doing some general stuff. I'm going to try and condense as much of palliative care as possible. I know we get very little experience in it, but we'll go over the most important bits. So we'll start off with the palliative care side, which is what is palliative care, when can we apply it, and the quite important bit for exams, which is the prescribing side of things. So quick overview of palliative care, which is essentially you're dealing with symptoms. You're not addressing the root cause, as is the sort of origin of the word. So the important thing with palliative care is obviously most of the time in our head it's dealing with end-of-life patients, but it generally, the scope is any patient with complex needs with symptoms which are very, very difficult to treat. So patients who are not necessarily terminal, but let's say with neurodegenerative disorders who still have a decent life expectancy, but are struggling with intractable pain or vomiting or so on. That's when you might call palliative care. But obviously a big part of it is going to be dealing with end-of-life patients. Just a quick question, what sort of defines a patient who is end-of-life? So if someone just writes that down in the chat, what is our sort of rough definition of end-of-life? So generally it's sort of seen as a person who is in the last 6 months of their life. How that's sort of reached is usually based on signs and symptoms, but there are also some scales used by palliative care physicians, for example. So moving on to the next bit, what are sort of signs and symptoms of impending death? Let's say within the weeks leading up to somebody dying, what sort of things might you notice, or you might sort of advise the family about that this is normal as a person starts, not acute death obviously, but sort of dying from something like cancer? What sort of things will happen in the patient that are signs that this person is going to die in the next few weeks, days? Yep, so appetite loss, agitation and reduced breathing, huge reduction in mobility. Pain can get worse usually as the disease itself progresses. So as the cancer gets worse, for example, the pain gets worse. Fatigue's a huge one, and secretions is a really important one, and quite useful to understand. Why do patients who are approaching the end of their life sort of start building up secretions? What's the sort of pathophysiology behind it? Yeah, perfect. So you reduce your ability to swallow, so things accumulate. So you have a weaker swallow, and as you get weaker, your diaphragm's getting weaker, your intercostal muscles are getting weaker. You can't breathe as deeply, so you can't clear fluid as well. So you start getting these secretions, which cause your horrible rattly breath sounds. Speaking of rattly breath sounds, anybody know a pattern of breathing that's sort of pathognomic of a patient getting quite close to death, so within days? Yeah, Cheyne-Stokes, like Christina said. And what is Cheyne-Stokes breathing? Whilst waiting for that, the important thing with Cheyne-Stokes is that the patient isn't suffering during it. It doesn't really distress the patient. Who it's distressing for is the family, and that's a big part of palliative care. You're also, yeah, perfect. So like Paulina said, the patient sort of what you notice with the patient is their breathing sort of slows down until they just stop. They have a period of apnea, and that could last up to 2 minutes where they're just not breathing. Usually it's about 45 seconds. And then what that happens is, as they're not breathing, obviously CO2 levels rise, so suddenly they get this huge CO2 drive and they start breathing quite deeply and rapidly. So after a period of not breathing, they'll go, like Christina said, they'll gasp, and then they'll do that. And then again, as CO2 levels drop, then they go into apnea again. And as your cerebral perfusion drops to your pons isn't really working as well. So as a sort of quick overview, fatigue and weakness, like a lot of you said, in red is sort of the physiology behind it. So remember, as your heart's getting weaker, your cerebral perfusion goes off, which is a lot of the reasoning behind why patients become withdrawn, quite agitated, decrease, sometimes hallucinating, restless. You get sort of the cardiac signs, so patients becoming more mottled, cold periphery, sometimes even cyanotic, periods where you just cannot feel a pulse. The things I've highlighted in blue are part of what I call the big four of palliative care. So if we move on to this bit, so the four palliative giants, so I highlighted agitation because treating anxiety and agitation is a big part of palliative care. Analgesia, so a patient who's approaching the end of life may not necessarily be in pain, but a lot of them are, because if they're dying from something like cancer, that is often very, very painful. Antiemesis, often you feel sick as you approach the end of life, and that's for many reasons. Cancer is amongst the most common. So this is more of a thing in patients who are dying of cancer. But what's another reason tied into analgesia? Why might a patient who's needing a lot of analgesia feel sick? Opiates, perfect, yeah. Palliative care is centered a lot around the prescription of opioid medication, and obviously a huge side effect is feeling sick. And we've got anti-secretion, which is a really, really big one. So we've got the first SBA. So we've got this first point of this is a young person, and palliative care can look after young people as well. So patients with leukemias, severe neurodegenerative disorders. So it's not just a specialty which deals with old people. So we'll give you about a minute for this. This is a 24-year-old man. He's coming with hyperactive delirium, and his past medical history is severe nonverbal autism, so he can't talk. And he's got an inherited early onset version of Parkinson's disease, which is about 5% of Parkinson's disease is like that. The thing's got a UTI. They start him on treatment. He needs pharmacological management for his delirium, and then 30 minutes later, he's in bed looking like that. Which of the medications that he might have received is responsible for this? I started off with a hopefully quite straightforward one. And there's 27 of you, so Anush, let me know when most of them have.
Yeah, I will do. Most people have gone for the right option so far. Have a go. It doesn't matter if you get it wrong.
Yeah. But if someone wants here, you can just type down what the diagnosis is.
Yeah, that's also good practice. Yeah. Speaking of getting things wrong, all Ahmed and I have been doing are like practice PSA questions where we just get stuff wrong.
Yeah.
Because that's the best way of learning.
No point sitting down with the book, in our opinion, when you can just do questions. And
especially for the PSA, yeah.
Yeah.
Right, so seconds.
Yeah, so like Lizzie said, this is dystonia, more accurately acute dystonia, because it wasn't there half an hour ago. You can get chronic dystonias, which are horrific, but acute is by far the most common form.
So there was a bit of a split between olanzapine and levopromazine.
Okay, right. So the right answer is levopromazine. We'll talk that through. So just quickly, nitrofurantoin, it's got no link. So this person, like Lizzie said, has got dystonia, which is an extrapyramidal side effect. Remember, that's centered around anything which antagonizes or destroys the dopaminergic system of the basal ganglia, so Parkinson's disease, but also anything which is a dopamine 2 receptor antagonist. And the most famous example of those are your antipsychotics. Now, olanzapine is the second best answer here. Aripiprazole and olanzapine are both atypical antipsychotics, which means that whilst they do bind to the dopamine 2 receptor, they have a far lower affinity than levomipramycin, which is a very old antipsychotic, which nowadays isn't so much used for things like schizophrenia as much as it's used for things like treating acute delirium, because you IM injection it and it acts quite quickly. Lorazepam's got no link to extrapyramidal side effects. So olanzapine, to get somebody to have acute dystonia with olanzapine, the top dose of olanzapine orally is about 20 milligrams. To get somebody to have acute dystonia with olanzapine, orally at least, you'd have to give them maybe like 40 or something. You'd need to give them a very big dose. Whereas the typicals, because they've got a much higher affinity, are more likely to cause it. But olanzapine's a fair bet, and we do use IM formulations for it for sedation as well, because they're less likely to cause acute dystonia. But that's more in psych units rather than in hospital. Before moving on, what two things does this patient need? Clue is one for the dystonia, one for the Parkinson's, because he's a Parkinson's patient. And the answers to that question are going to be in the notes. So what do we treat acute dystonia with? What's the reversal agent? Procyclidine, perfect, like James said. So an antimuscarinic. There are muscarinic acetylcholine receptors in the basal ganglia which appear to be in favor of kinesis. And then any patient who's coming in and let's say they might not be able to swallow or something like that, where they might not necessarily be able to regularly take their Parkinson's medication. What do we need to do for them? Yeah, sorry, the question was supposed to say that he's vomiting as well. So salt referral definitely be warranted, but how are we going to cover him for his medication in the meantime? His Parkinson's medication. Could do a depot. It's actually, depots are more for dopamine antagonists, so the antipsychotics. You can find dopamine agonist patches. So the thing that they'd use a patch. So you have something like ratididine, which is a dopamine 1 receptor agonist, and you'd use that to cover. Let's say he was taking something like Sinemet, which is combined levodopa carbidopa. So you'd want procyclidine. James is right. You'd want a salt referral as well. But the two most urgent things are procyclidine and cover him with a dopamine agonist patch if a patient with Parkinson's can't swallow. Right. So delirium and anxiety is probably the most straightforward one. You probably remember your delirium stuff from when Anush did Jerry's. They usually respond quite well, actually, because it's a more straightforward thing. James asked, how do patients usually on levodopa respond to dopamine patches? It's quite good because you don't have the sort of on-off effect that levodopa has, which is why we kind of leave the dopamine 1 agonist as a last resort. Because they're better, so may as well leave them for when the patient actually needs them, because they're more expensive. And they also have their own set of side effects, like the behavioral syndrome that comes with them, so compulsive gambling, hypersexuality, that sort of thing. But usually you can switch somebody quite well from levodopa if they're using it to a dopamine agonist patch. So anxiety stuff, same as delirium, always start conservatively. So remember your conservative measures. Is there something reversible? Just because somebody's palliative doesn't mean we don't necessarily treat things. You might not treat something life-threatening. Let's say if a patient's got an advance directive saying, if I get pneumonia, don't take me into hospital, just make me comfortable. But if there's something reversible, like they've got urinary retention, then relieving that with a catheter, unless the patient has explicitly mentioned that that's not what they want, is entirely sensible. Your other conservative measures, so dimming the lights, loud noises, so this is where side rooms become really useful, trying to recreate a friendly environment, so having a relative in. In terms of pharmacology, your first lines are generally, if a patient's acutely delirious, your typical antipsychotics, so you've got haloperidol or levopromazine, contraindicated in Parkinson's. We kind of just did that. You can give those either as sort of maintenance if the patient keeps on having delirium, so it's 2 IM injections a day. But if it's a continuous thing, then it's usually often just way kinder to do it as a subcutaneous infusion, which we'll talk about once we do syringe drivers. Syringe drivers are much kinder than repeatedly giving somebody an IM injection. IM injections aren't particularly pleasant, especially if you're sort of not really with it. If the patient on top of it is restless and confused, so the problem with haloperidol and levopromazine is that they're good at calming people down and sort of making people quite docile. They're not particularly sedative. They don't really sedate people. The good thing for that is midazolam. So what you can add on is midazolam. Sometimes you'll find people combine them, but let's say you've got a patient, especially if there's one who's having seizures because of, let's say they've got a space-occupying lesion or they're dying of brain mets, then midazolam's great because that can go in the syringe driver as well. But the anxiety and delirium side is the most straightforward, ideally an antipsychotic, but if that's contraindicated or the patient on top of it is restless, confused, then midazolam's a fair shout. Right, excessive secretions, noisy breathing, and painful bowel colic. Excessive secretions and colic are all going to be products of which part of the nervous system being given free rein. What drives secretions in the digestive tract and also contractions of the GI wall? Perfect, parasympathetic nervous system. So it goes to it logically goes that what medications are going to be our friend here if we're trying to deal with the parasympathetic nervous system having too much activity. Perfect, anticholinergics, specifically antimuscarinics. So everything on this side is driven by the sympathetic nervous system appears to go before the parasympathetic as a person is dying or getting older. So, which is, you get your postural hypertension. You also get older people getting more colicky. Constipation side of things would work against the parasympathetic. That's usually to do with medications they're taking. So, antimuscarinics, like you said, treatment of choice. So we've got some choices. There's a medication called glycopyrronium bromide, which is an antimuscarinic. Old days, I used to use atropine. We don't like atropine now because it's very non-specific and you can give people pretty bad bradycardias, so no to atropine. The two ones that you'll see mostly are hyoscine hydrobromide, which is scopolamine, and hyoscine butyl bromide, which is buscopan. So that's the one that you normally give for people who are dealing with horrific muscle spasms. We like butyl bromide because, remember, anticholinergic burden. We don't like it when anticholinergics can cross the blood-brain barrier because they contribute to confusion and impaired cognition. Hyoscine butyl bromide is a modified version of hydrobromide, and it's not good at crossing the blood-brain barrier, so it's far, far less likely to cause it. It doesn't really cross as well. But hyoscine butyl bromide is just generally better. It doesn't need as high a dose, and it's better tolerated. And its advantage over hydrobromide on top of the fact that it doesn't cause delirium is, oh yeah, atropine causes tachycardia. Sorry about that. Slip of the tongue. Thank you, Anush. On top of it, it's got better action on the muscarinic receptors, which supply the gut, the actual musculature of the GI wall. So the way you can remember it is butyl bromide does both secretions and colic. Prescription-wise, you give it every 4 hours. If they're needing it more than, generally given 4 hours. I made a typing mistake there. As in, yeah, if they need to be given more than every 4 hours, so that's supposed to say if they need to be given hourly, sorry, I'll change that afterwards. If they need to be given, let's say, every hour because the person's having horrible secretions, then you can consider putting it in an infusion. What are the problems with antimuscarinics? What side effects are we going to give that patient? Yep, put them into retention, which is very unpleasant. Constipation, which is unpleasant. Dry mouth, good. I like that people said dry mouth because people often forget that, and that's really unpleasant when you're dying. It's really unpleasant generally, but dry mouth is an important one. So you need to consider things like mouth care and possibly prescribing a laxative. Just something to be aware of because prescription errors do happen here. Hydrobromide has a far less lower, not less, lower effective dose than butyl bromide. So if you, let's say, put hydrobromide when you meant butyl bromide, you could really OD a patient on an antimuscarinic and put them into sort of anticholinergic crisis. Right, next SBA. So we've got Hugh Jenkins, who's 73. He's got stage 4 prostate cancer and he's on palliative radiotherapy for bony mets. He's recently gotten really bad nausea and vomiting and his GP sent him to ED. He's given a stat dose of an antiemetic. The medical team reviews him and admits him for rehydration, but they also start him on a different antiemetic. 2 hours later, sorry, the ECG's clipped over that, the nurse pulls the emergency buzzer because they found Hugh unconscious, and you've got this ECG, which is showing the following. Which medication is most likely responsible?
I was just going to mention on the previous slide as well, it's probably worth just remembering one, just pick one and remember the dose for one. So
just
you don't
pick
get
butyl
confused.
bromide.
Yeah, just always.
Just don't go with just go with butyl bromide. It's
Yeah.
first line for a reason.
Yeah. This is a fun ECG.
And yeah, if anyone's not answering it, you can say what you think the ECG is in the chat. So what does this ECG show?
So there is a bit of a split between A, B, which are the most popular options, and E. A and B are very popular.
Okay. Right. What? Someone will have a go at what ECG is.
To be fair, it's a bit of a mess.
Perfect. This is a polymorphic ventricular tachycardia, and usually what's one of the biggest risk factors for a polymorphic VT? What problem with the, well, I was about to say what problem with the ECG? Well, what ECG feature? Yeah, perfect, long QT. So the question here is, which one of these medications elongates the QT interval? No, don't worry about it. Yeah, so this is a useful one to know. I only learned about it recently, but ondansetron is the only one out of these that causes QT interval prolongation, which is why ondansetron, it's really good for nausea and vomiting caused by chemo or radiotherapy, which is why we like it, except it also elongates your QTc interval. So if somebody's got some form of underlying heart disease, maybe not ondansetron. Right, nausea and vomiting. So what neurotransmitters are involved in nausea and vomiting? And I will save you some time and say practically all of them. Dopamine, serotonin, acetylcholine, histamine, opioids. This is why a lot of the antiemetics have. Does the ECG go back to sinus? Is this normal for... Right now, let me go back. Yeah, I have no idea what happened there. I'm assuming that might be the point that the patient was shocked. I don't actually know. That's a good question because it does basically go back to sinus. That's not normal. It won't go back to sinus because the person usually dies if it's not treated. So I'm assuming that's the point at which the person was successfully cardioverted, which is good. But yeah, that's not normal. Right. So all the neurotransmitters. What medications cause it? We already mentioned it earlier. Opioids. What other treatments? Chemo, radiotherapy will do it. What sort of metabolic abnormalities perhaps might cause a patient to be vomiting? Say you've got a patient with bony mets. Why do they vomit or feel nauseated? Perfect. Hypercalcemia. Hypercalcemia causes you to feel nauseated and vomit. Okay, so if it's opioid-induced nausea and vomiting, you don't actually need to continuously treat it. Usually they only need 4.5 days worth of treatment for it. So let's start with what are our options for treating nausea and vomiting. So we've already said ondansetron, which is good for chemo and radiotherapy-induced nausea and vomiting. What do people reckon the first line might be? It's a drug that was already mentioned, which is actually kind of why it's a useful drug. Yep, so cyclazine's a good option, especially if you don't know why they're nauseated. It's generally quite safe. There are drugs that treat another symptom that we mentioned earlier, which also, because perfect, haloperidol. So your typical antipsychotics are quite good at dealing with nausea and vomiting because they antagonize everything. They're very dirty drugs. So haloperidol is great for this sort of thing. And because it's a two birds, one stone drug, it's often quite commonly used, especially because in syringe drivers, usually the max number of medications you can put in is 3. It's good for metabolic causes as well, and because it's mainly metabolized almost completely in the liver and you don't really get much active metabolite left over, it's good for renal failure as well. Also, its half-life is really long. We've mentioned levopromazine, less sedative than haloperidol. More sedative than haloperidol, and if someone's nauseated and actually vomiting, you probably don't want to sedate them because risk of aspiration. Metoclopramide, we've all heard of, and that's good because why is it good for causes like ileus? So let's say somebody is vomiting because they've got pseudo obstruction and they're vomiting things back up. Why is metoclopramide great for that? It's prokinetic, exactly. Thanks, James. Yeah, so it's great for that. However, because it is prokinetic, what drug class, which is also commonly used in palliative care, is going to antagonize it directly and make it less efficacious? Opiates, one of them. What drives peristalsis? And what medications do we commonly give that block Yeah, perfect, the anticholinergics. So often these patients are an anticholinergic because of their secretions, and then you give metoclopramide and they kind of both cancel each other out a bit. That's one of the problems with metoclopramide, on top of the fact that if a patient goes into bowel obstruction, bad. Cyclazine, like Adam mentioned, it's good for bowel obstruction because it's not prokinetic. It's good for if you don't really know why they're vomiting. We've said ondansetron for chemo. And octreotide you will not see often. So what is octreotide, first of all? Perfect, a somatostatin analogue. Remember, somatostatin's effect on the GI tract is mainly to slow things down. It's sort of got an antagonistic effect. So it's good for people who've, especially neuroendocrine tumors, because it's a hormone in itself and it acts against things like serotonin. Serotonin's prokinetic, so let's say you've got carcinoid syndrome, octreotide will reverse that. You won't see it often, it's expensive, so unless they really need it, they won't use it. And then if one isn't enough, double up with a different one. Obviously, like if let's say they're not responding to an anti-D2 receptor like haloperidol, there's not really much point adding on metoclopramide. So you'll see combinations like metoclopramide and ondansetron, for example. Right, so that's nausea and vomiting. Pain, which is the bit which we're all here for because that's the most common one. What is our gold standard? What is our gold standard analgesic in palliative care? That everything is relative to. Morphine, like Lizzie said. And why is morphine great? Why is morphine our gold standard? What makes it so good? Perfect. Lots of different forms. You can give it however you want. You can give it orally if the patient's well enough. Patient vomiting, you can give it I am. Patient needs a syringe driver. You can give it subcutaneously. You can give it intravenously. Other opioids don't necessarily have that, as we'll see. So it's really, really good for that stuff. Right. So if a patient is in pain, how are we going to start them? And you followed your pain ladder and it's not responding to paracetamol or cocodamol, and you realize, okay, I'm going to need to move on to a stronger opioid. How are we going to start the patient? So what I mean is, are we going to straight away start them on a regular dose? Are we going to start them on a PRN dose? What kind of dose are we looking at? Because as an F1, perhaps you might be doing this where patient's complaining of some pain and, you know, it's not responding to the lower tiers and you think they need morphine. Yeah, perfect. Literally that. So Paulina's got it spot on. You are not really going to, unless there's a pretty good reason for it, you're not going to start a patient on a regular morphine if they've never had it before. Start them on a PRN, 5 milligrams a good starting dose. You might start it a bit lower if they're particularly old or frail, or if they've got a degree of renal impairment. Let's say their GFR is around 60, but 5 milligrams PRN is entirely, you know, that's entirely reasonable. As an F1, you'd probably be pretty happy to start that. Usually if it's regular, so if PRN is the immediate release, which makes sense. There are modified releases, which are slow release forms, and that's your regular medication. Let's say you've got your patient who's on the PRN and they're using it very frequently. And by very frequently, let's say they're using it 6 times a day. Then you're starting to think about a regular dose of morphine. Now, to start the idea of your sort of regular dose of morphine, you're probably going to want to add up all the PRNs that are being used and then start that as a regular dose. So let's say our patient who is using 5 milligrams 6 times a day, that's 30 milligrams. So 30 milligrams a day would be their good starting dose, reasonable starting dose, and then you can up titrate from there. Because the modified release usually covers 12 hours, usually patients on morphine, oral morphine at least, will be taking it as a BD formulation. So once in the morning, once in the afternoon. When you prescribe regular morphine for a patient, what is it also important to prescribe on the PRN side of things? Do we just stop giving them PRNs, PRN morphine? What do we need to cover for? Yep, so laxative is really important. But then the other thing is they still need their PRNs because of something called breakthrough pain. So breakthrough pain is pain that's coming in between regular doses. Pain is regarded as controlled if with the regular medication you are not getting pain. It is uncontrolled if you're having to take. Yes, absolutely, yeah. The names and so on are very, very confusing, yeah. So Oromorph is your immediate release oral morphine. The other ones you will see written as modified release morphine sulfate generally, but if you see Oromorph, that's the one where you want it straight away. Generally, it's bad practice to write trade names as we're taught, but you'll see doctors do it, which is annoying. But Oromorph, if you see it, is fast release. So let's say you've got your patient who's taking 30 milligrams twice a day. So that's a total of 60 milligrams. How do we decide what her breakthrough dose should be? So the dose she should be taking PRN if she needs. Yeah, Oromorph is PO. So Oromorph oral morphine is the idea of the brand name. They thought they were being clever. But morphine sulfate, which is a sort of, that comes in ampules and so on. So that's usually the IV one. The immediate forms and stuff you only need to worry about in terms of oral, because if you're giving it IV, it's immediately immediate. Sorry, I just made that up. But Oromorph is an oral form. So how do we calculate breakthrough pain, sort of the PRN for breakthrough pain? This is one bit that's quite important to remember. So this figure. So breakthrough pain, the breakthrough pain dose is 1/6 of the total daily dose. So your patient is taking 30 milligrams BD. Yeah, perfect. Sorry, Christina, I should have waited a bit. You divide the total 24-hour dose by 6. So patient's taking 60 milligrams BD, then that's 10 milligrams on the PRN chart, which the patient can take anytime they are feeling pain in between their regular doses. They can take this up to 1 hour, but if it's reached that point, they really should have their regular dose upped. So that's what that was supposed to be in the blue box. It's formatted weird. Our apologies, and that's what we said. So the overall dose is 60 milligrams, so the breakthrough is 10. In terms of other useful things to know, if you know that you're going to be doing something to the patient which hurts, like dressing their wound or moving them, give a breakthrough dose 30 minutes before. If they're requiring their rescue doses a lot, then we need to up the dose. This bit's a bit annoying because you hear different sources. So some people will say how to calculate the new regular dose is add up everything that they're taking. So our patient who is taking 60 milligrams a day regularly, 30 milligrams twice, and has 10 milligrams as her PRNs. So let's say she's using that 4 times a day. So she is using 100, she's using 100 milligrams of morphine in a day. Some people will say that is your new regular dose. So the patient is now on 50 milligrams twice a day. Some people will say up it by a third. So the patient is now on 133 milligrams of morphine. Some people will say up it by a half. So the patient is now on 150. Learn one, stick with it. I think the safest one is the total dose with the PRNs is the new dose, because that obviously minimizes the risk of opioid toxicity. You will see some people do it differently, local guidelines, practitioner preference. But if I give you a question, I'm going to tell you what factor to multiply by. But the important thing is whenever you're thinking of upping the dose, add up everything. And then depending on practitioner preference, guidelines, whatever, then you can modify that, whether you make that the new regular dose or whatever. So let's say this patient, let's say you were upping it by 50%. So we're saying that she's on 100 milligrams. So upping it by 50% times 1.5 is 150 milligrams. Does the rescue? Yeah, the rescue dose is rescue is just synonymous for breakthrough. Sorry about that, should have been clear. So the new regular dose is 150. So now they're taking 75 milligrams BD. Does that make sense? If that doesn't make sense to anyone, because this is quite important, say so, or go through it again. So you add up everything they're using in a day, regular and PRN. 40 comes because she's using 10 milligrams, her breakthrough pain 4 times a day. So that's the total of her PRNs. So she's on 60 regularly, but she's also using her 10 milligrams 4 times a day. So her total daily intake of morphine is 100. So let's say if you were being conservative, like I say Anush or I, you'd make her new dose 50 milligrams BD. If you were maybe a palliative consultant, you felt quite confident and in your prescribing, you might up it by, what the example says. You'd never up it by more than 50% though. So this example, this worked example, is the highest it would ever really go. Otherwise, you're really risking toxicity.
And if it's a station, I'd imagine they'd give you some local guidance on how much to increase it by. If they don't give you any local guidance, you act as an F1, which is you just add them all up. You go for the lowest possible estimate, I would say, if they don't give you any guidance. But I'd be pretty confident that they'll give you some idea of what to do.
Yeah. So let's say in this question, I've specifically said increase it by a third. So have a go at this. So this lady's taking 60 BD and she's using her 20 milligrams. So IR is immediate release, so that's the Oromorph, MR is modified release. She's using that 6 times a day and increase the dose by a third. Whilst they're doing that, Anush, should we do the deprescribing stuff and then we can do the other opiates at a later date, just in the interest of time?
Nah, just continue. It's fine.
Okay.
As in we can do more Jerry's at some other point. I just think palliative care is more important, and I think doing the syringe drivers is probably quite good. If year 5s have any thoughts on that, let us know. Oh, is it open? Yes, it is open.
These sort of questions, unfortunately, do turn up. It's annoying because all the options kind of look the same, but if you stick to the whole one sick thing, and hopefully they'll tell you by what factor they want you to do it by, then you're fine.
So remember to add up all of the regular modified release as well as every time she uses immediate release. God, maths is a thing.
Yeah.
You can have 20 more seconds because there's a lot of math.
Yeah.
Well, a lot of math with respect to the rest of the degree.
Yeah, a lot of maths for medicine.
Yeah. I just got an email saying I'm in the top 1% of Mentimeter users. Clearly, Mentimeter isn't that popular.
Or maybe you just really use it a lot. You don't.
Right, so most popular option is C followed by A.
Okay. Perfect. So let's talk through those. So C is the correct answer. People who went for A, you've got the right amount. Just remember, morphine, generally, the regular morphine is split between 2 daily doses because modified release works for about 12 hours. So you've got the right answer. Just remember that it's usually BD. So to quickly go through the working, her overall daily dose is 240 milligrams because she's using 20 times 6 of her PRN, and her regular is 60 times 2. Upping it by a third gives us 320, which is the new regular overall daily dose, which is given as 2 halves. And a sixth of the overall dose is 53, and you always round down. Realistically, this is going to be rounded down to like 50 milligrams because there's no 53 formulation. Is anyone confused about that? Because I do want to make sure everyone's happy with this, because these questions come up and they can be quite annoying, but once you're happy with them, then they're fine. If anybody isn't, put it in the chat and we can go back to it.
And also, yeah, if anyone doesn't get palliative care prescribing, just message like after today, just message one of us, and then we can go through it, because like this is like there's 2 prescribing things that can come up in palliative care, and one of them, like almost like at least one of them will probably come up. So it's like a mark or a station at least.
Like I'm teaching it, and it took me till the end of last year to feel happy with it. Okay, quickly, here are the alternate doses. Some people advocate learning them. There are a few which are definitely important to know. So we're using morphine, oral morphine, as our standard here. So that's what I've highlighted in red in the middle. So 10 milligrams of oral morphine is equivalent to 100 milligrams of codeine, tramadol, or dihydrocodeine, and these are all oral. So it's 10 times stronger. Oxycodone, and this, if we're talking about brand names, you will see this as Oxynorm. So Oxynorm is oxycodone, not morphine or anything, which is an alternative synthetic opioid. That's a bit of an annoying one. It's about 2/3 more potent than oral morphine. So 10 milligrams of oral morphine is about 6.6 grams of PO oxycodone. Hydromorphone is one that you might not see too commonly. It's usually a third line. That one's quite strong. It's 7.5 times stronger than morphine. This is the important one. So any parenteral version of morphine, so that's IV, subcut, and IM, is twice as strong as the oral version. So if you are switching from oral morphine to a syringe driver, you will halve the oral dose. That number is one that you should remember. The other ones, not really that important. They might ask you, they might not, but the most likely one is asking you to convert oral morphine into a syringe driver because the patient can't take oral morphine anymore. Notes on the side, opiates generally aren't great for the kidney. The problem with the liver is that it does metabolize your opioids, it just doesn't really metabolize them completely. So they are excreted renally, and because there are active metabolites, they tend to accumulate, and that's what causes opioid toxicity. Some of them you should stop using at a higher level, but generally, if it's 30 milligrams, if it's GFR's below 30, then it's not, but yeah, you probably shouldn't really be using morphine or these other ones. Oxycodone is when patients are intolerant to morphine. When I say intolerant to morphine, I mean things like they get really sick with morphine, they vomit a lot, they can't tolerate it, essentially. That's when you use oxycodone. Hydromorphone is your sort of fourth line. Nice one, James. Um, Hydromorphone is a fourth line, and then diamorphine, which is heroin, is a third of the is a third of the strength. Sorry, 3 times as strong as oral morphine. No, he's got it. It is 100. It is about 150 times 100. No. Oh, you mean? Oh, Jesus. Okay, I did not know that. I did not know about carfentanil. Okay, and the good thing about diamorphine is that it's more soluble than morphine, which means if you're giving a really high dose, then you can squish it into a smaller volume because diamorphine is stronger and more soluble. So the important one that I want you to remember is this one, which is subcut morphine, half as strong, twice as strong. So half the dose, 10 milligrams of oral is 5 milligrams of subcut. Quickly going over the continued ones, you might wonder, what do I do if their kidneys are shot? You've got alfentanil and fentanyl. Don't confuse the two because fentanyl is 4 times stronger. So prescription error will OD the patient and possibly kill them. So alfentanil, either they're intolerant to the previous one, so morphine, diamorphine, oxycodone, or their GFR is under 30. Because the liver completely metabolizes it, you don't need to care about their GFR. Doesn't matter. It's great. It binds to protein really well, so it gets metabolized really well by the liver completely, and if there's any of it in the circulation, it won't go out through the urine because it's strongly bound. It's strongly bound to proteins. This means that you do need to reduce the dose in hepatic impairment, and also it will be influenced by your P450 system, so your quinines, your macrolides, etc. It's 30 times stronger than morphine. You don't really give it orally. These two are just really they're not oral. If you're controlling an infusion, then consider switching to patches. So fentanyl, this is when a patient is stable. So remember earlier we said stable pain is when the patient isn't needing their PRNs. Their pain is controlled on their regular dose. Then you can consider switching to fentanyl. You can't give it orally or subcut, so it's given as patches. It's got the same interactions as fentanyl in terms of the P450 system. And if you're stopping somebody on alfentanil or starting them on a patch, then you put the patch on, and 12 hours later you can stop the alfentanil infusion. Don't ever use it in someone who's never had an opiate before, because you might possibly knock them out because it's really, really strong. I thought it was the strongest opiate until Anush mentioned carfentanil, and it's about 150 times stronger than morphine, like James said. So the conversions are there. So is it worth learning them? I wouldn't say so. Anush is shaking his head as well. I wouldn't bother learning them. I think a good rough value is to know it's about 150 times, and then you can sort of convert it from there. They are expressed as the hourly dose. So you'll see fentanyl 25, that means it's 25 micrograms per hour. And just a reminder, kind of what Adam touched on earlier, if you're giving an opioid, give them a laxative, give them an antiemetic, and also prescribe naloxone in case they go into opioid toxicity. So, fourth SBA, the last SBA from my end, is the lady from the previous SBA is getting more and more unwell, so she's getting closer to dying. She's got a GFR of 17 now, and she can't swallow. Her pain was stable on her morphine that we prescribed earlier, but you need to change her analgesia. LFDs are fine. She's not using her PRN, so she's got her 160 milligrams BD that we prescribed last time, but she's not using her PRNs. What should we change her medication to?
10 more seconds. Sorry, I know you'd get more time in an exam, but we do want you to go and have dinner at a reasonable hour. So bit of a split between A, B, and D. A and D are most popular.
Okay, so for the people who've gone for anything other than C, you've all gone for the right dose. The main thing here is her GFR. So the correct answer is D. If she didn't have severe renal impairment, A would definitely be the right answer. Morphine is gold standard anyway. So you'd be absolutely right. You'd half her daily dose, and that gives you 160 milligrams. However, because her GFR is 17, alfentanil is going to be the most appropriate thing here. 107 milligrams of diamorphine is the right dose. 107 milligrams of oxycodone is the right dose. But it's because of her renal impairment. Finishing off, at least from my end, syringe drivers. So people get really sort of worried about syringe drivers and so on. You're not going to be prescribing them as an F1 or an F2, maybe as a GP, but otherwise you're not. But to make it straightforward, first of all, why might we put somebody on a syringe driver? What are the indications for a syringe driver? Yeah, perfect. The biggest ones, they can't tolerate oral meds. So the usual things, have they got really bad dysphagia because they've got an esophageal tumor? Have they got a weak, poor swallow? Are they GCS 9, for example? Maybe a malignant bowel obstruction, which isn't going to be treated, and you really don't want to, you don't want to put in an IV infusion or an NG tube. And the last one is obviously if the patient doesn't want oral meds and they have capacity, then can't really force it on them. Here are the basic things with syringe drivers. You don't need to know about this at this point really, but there are certain medicines that don't mix well because they precipitate, they react with each other and they precipitate. And there are some meds which just don't really go in syringe drivers because they cause local reactions like swelling and burning. So diazepam's a good example of that. It's why we use midazolam instead. So some medicines just don't go in syringe drivers, and if you're going to put them in, always double check to see if they can actually work together. There are actually on the slide after next is a good website for that. Usually you use water for injection. Some people use saline, but the most common thing is water for injection. UCL will always teach you to prescribe 24 milliliters at a rate of 1 milliliter per hour for a day. In reality, how many people have seen 24 milliliter syringes? No one really. You usually see 20 and 50s, and you can imagine how many 50 milliliter syringes would be wasted if we only half filled them, threw them away after a day. So usually people use a 20 ml syringe, fill that up to about 17 milliliters and run that over the day. But if you're prescribing in an OSCE or something, which would be really mean if they made you do a syringe driver, then you would do it 1 milliliter per hour and a total of 24 milliliters. So you literally add the drugs to the dose that you need, and then you just add the water. So let's say you know that you've added 2 milligrams of a certain drug and then the other drugs, and then you just add the water until it reaches the volume that you want. Here's a practice conversion.
Yeah, I added this in just before we started. Have a go at this. This is why I said bring a blank piece of paper. It doesn't matter if you have no idea how to do it. Just pretend you have like a drug chart. Think about where you'd write it and what you would write. You can have like we can do the Jerry's another time. Just spend like a couple of minutes thinking through what you're gonna write. We'll show you the right answer in a minute. But like, yeah, as Ahmed said, it's like a harsh OSCE station, but like it's also not like it doesn't have a 0%. Yeah, it doesn't have a 0% chance of coming up. And like we definitely had a case of the month on it last year. We had a case of the month on it this year. So like it's something they want us to know about. So yeah, have a think about how you'd prescribe it. And we'll show you the correct way to do so in a minute. So, so some of you might have gotten a bit further than others. So just to start off with, what section of a drug chart do you reckon syringe drivers go in? So there's two correct answers. There's a correct answer for UCL exams on our terrible prescription chart, and there's a correct answer for real life. Unfortunately. Any ideas what sections you'd go for? Just pop in the chat.
Yep. So fluids go, so the infusion section.
Yeah. So if this comes up, they'll give you the good hospital drug chart, and that is exactly where you're going to put your syringe driver. In real life, often some drug charts have extra sections for syringe drivers, which are prescribed separately, but you don't need to worry about that for exams. You'll learn that when you're an F1 or a final year.
Here's how UCL want it done. So water for injection, 24 mils, and then, like we said, 1 mil an hour over 24 hours, and that's how you put the drugs.
Yeah.
Now remember, we've halved the morphine because she's taking 30 BD orally, and the Midazolam dose doesn't really change. It's the same amount of Midazolam.
And
right.
And obviously, yeah, you'd sign and write the bleep and stuff if you're in an exam, but we're lazy. Sorry.
Yeah. And then this last, sorry. Yeah, basically, that's the most likely thing, James. It'd be a real, I'd say, dick move if they went, okay, now convert oral morphine to fentanyl patches or something like that. That would be,
yeah,
pretty mean. The most likely thing, because the most commonly done thing, is convert oral morphine to subcut morphine. So just remember, divide by 2. Yeah. Which a lot of people sometimes forget to do. So I forgot to do it in PSA questions.
As in the other stuff. Yeah, so like I wouldn't worry about those. Like if they come up, they'll give you a BNF. I did check when I made this into a quick case. I did check, but it is the same dose. But they won't ask you that. They want you to know like pain relief conversions. They don't care about other stuff. You can look the rest of it up.
So
why? Yeah, sorry. Go.
So half the dose, because when you are doing something orally, it will have its first pass metabolism through the liver. The liver does metabolize morphine. So the 30 milligrams doesn't mean that 30 milligrams will reach it. Whereas if you're doing it parenterally, so IV, IM, or subcut, you bypass the liver. So you don't need as high a dose to mean that the same amount gets to the desired site of action. Hopefully that makes sense. Basically, because you're bypassing the liver. And then just a roundup, we won't talk through these, but this is just sort of a reference slide. These are less likely to come up, but just useful to know once you start working or once you're on the wards. These are other meds that you'll commonly see in palliative care. A lot of them you'll know: bony pain, bisphosphonates, neuropathic pain, TCAs, gabapentin. But things like hiccups and metoclopramide or intractable coughs and morphine might not be as sort of common. And yeah, this website is my recommendation for if you're going through palliative care. It's got info sheets for basically all of the most common medications used in palliative care in terms of doses, indications, contraindications, how to administer them, etc. Sorry that we didn't get to do the Jerry stuff, but this is basic. The contents of this slide cover all of palliative care. We have not left out anything in a palliative care that could come up in the exam. So if you're revising palliative care, it is these topics. This is all of palliative care.
Yeah. If you go back a slide, it's also just worth mentioning. Yeah, so they really so we'll do some oncology at some point, but like out of your oncology weeks, which are also an important part of Mod C, the thing that they like asking the most about is oncological emergencies, which some of these drugs are also used in. So if someone, what?
One of these drugs.
The only drug
that matters.
Yeah. So dexamethasone is obviously commonly used, but they use bisphosphonates sometimes in hypercalcemia, which is a bit of an emergency at times. Yeah. But yeah, so Yeah, a few people messaged me like, what are you meant to learn on Onc-Week? You're meant to learn the oncological emergencies. That's like the
Even
biggest
Ursula
takeaway.
McGovern has said, so the head of the placement had literally told me, we
Yeah.
know that as F1s you're not going to be prescribing chemo, so we don't want you to learn dosing regimens for how to treat lymphomas and so on, RCHOP and whatever. It's the F1 stuff, which is managing oncological emergencies, so cord compression, SVC obstruction, hypercalcemia, and if in doubt with those, dexamethasone, 8 milligrams BD is what you do.
Yeah, for most of them. I'll stop the recording there.
Right.